Welcome to In a Heartbeat, coming to you from the studio of WMTV Channel 5 in Grosse Pointe Farms at the Grosse Pointe War Memorial. We are broadcast also throughout southeastern Michigan on AT&T U-verse on Channel 99, and now also the WOW Network as well. I'm Dr. David Balle, and I'm your host for In a Heartbeat. You may think that diabetes and thyroid abnormalities are conditions that only adults are vulnerable to. Well, unfortunately, they're not. And this brings me to my special guest today, who is a pediatric endocrinologist treating children with hormonal abnormalities. He has an interesting story to tell about the path of his career, and he will share with us some valuable information that I am sure you will want to hear about. I would like to introduce you to Dr. David Transue. Dr. Transue, welcome to In a Heartbeat.
Well, thank you, David, for inviting me.
It's my pleasure, and we have a lot of great things to talk about. And what I'd like to do to get started, Dr. Transue, is ask you, what exactly is a pediatric endocrinologist? And maybe you could also share with us a little bit about your practice and the types of patients that you see.
Well, pediatric endocrinology is a subspecialty of pediatrics. We are board certified, and we have additional training beyond our pediatric residency. We treat conditions that involve the glands in the body that secrete hormones in one place, but then travel to work someplace else. Mm-hmm. And as opposed to these are endocrine glands as opposed to exocrine glands. Exocrine glands, like the sweat glands and the salivary glands, secrete substances that work right there. Mm-hmm. Endocrine, like the thyroid gland, secretes thyroid hormone that affects almost every cell in the body. Mm-hmm. Diabetes is a condition that's due to a deficiency of insulin secretion, which controls the utilization of glucose. Mm-hmm. Or sugar, or our energy metabolism.
Mm-hmm. And so you see children who are afflicted with these disorders.
Right, correct. From newborn, in general, we treat from newborn to 18 years of age.
And where do you do your work, and where is your practice?
I practice at St. John Hospital, mm-hmm. and there are 4 other pediatric endocrinologists in the group.
That's great. Dr. Transue, what I'd like to do is maybe go back a little bit. And before you became a pediatric endocrinologist, you started out as a general pediatrician. And maybe we could go back and can you tell me a little bit about what it was like to be a pediatric resident at the time that you were a resident, and maybe compare that to a pediatric residency today?
Well, when I was a pediatric resident, of course, the pediatric subspecialties didn't exist. And we were more like an apprentice or had a mentor. And mm-hmm. We did not have a lot of didactic lecturing. We learned by taking care of patients. Mm-hmm. And I was a pediatric resident at Henry Ford Hospital for 2 years. Mm-hmm. Today, the teaching is much more intensive. Mm-hmm. And we do a lot of general lecturing. There are pediatric subspecialists in infectious disease and endocrinology, oncology, neurology. And so we have a much more intensive training for the general pediatric residents.
And so at the time that you were doing your residency, a lot of these subspecialties probably weren't really around. The general pediatrician did everything.
That's correct.
And you just kind of were thrown into the fire, and you started probably seeing patients very early on in your residency, and worked in close mentorship with your supervisors and your teachers.
Well, of course, residents still do. They begin seeing patients. They're right out of medical school. And when I was a resident, we spent 1 year in a general rotating internship before we decided on a specialty. Today, right out of medical school, they go into whatever their specialty is going to be.
You were sharing with me, Dr. Transue, that when you were a pediatric resident, you also you were married and you had children, and to help to support them, you did house calls, which we don't hear much of anymore. Can you share with us a little bit about what it was like to do house calls and what types of patients you saw with that?
Well, at that time, the families only had one car, and the dad took it when he went to work, and the mother was at home with the children. So there were a number of families that could not get to the office. Sometimes they would have a neighbor bring them, but residents were not paid at that time very much. My pay for residency covered my apartment or my house rent. That was it. So we would make house calls for pediatricians. In fact, for your pediatrician, I used to make house calls. And I might even have been to your house. I would get a list of patients that needed to be seen. But even after I joined that practice, we still made house calls, and sometimes we saw very, very sick children in the house.
I shared with you, it's interesting, I reconnected with you later on in life, and after I became a dermatologist, but I remember that my pediatrician at the time was Dr. DeMeso, and you had shared with, I knew I saw you, and I kind of think you did come to my house at the time to see me for something. I forgot what I had, but I think it was at night, and my parents were concerned. And anyway, thank you again for coming by and taking care of me. I appreciate that.
Well, you see, at that time, if you had that black bag, you were safe any place. I made house calls all over the lower east side of Detroit and in the suburbs, from Mount Clemens to Connor. And I never was threatened. But after I was drafted out of practice and went into the Army in 1968, when drugs had become when I came back and drugs had become such a problem, people no longer made house calls.
That brings me to something else I wanted to ask you about. So after you finished your pediatric residency, you joined a practice with Dr. Lee and Dr. Kim. Is that right?
No, with Dr. DeMeso.
Oh, okay.
Only. And then after a year and a half, Dr. Lee, who was a resident with me, and I
see.
We decided to go together and started a practice about a year and a half after finishing residency.
Okay. And then you were in practice together for a couple of years, and then you were drafted during the Vietnam War.
Right. I took care of, I was board certified by that time, so that when you were drafted and board certified, they had to use you in your specialty.
And that must have been, I would think that it must be difficult to leave a practice and take your family with you and go someplace else. And tell us what that was like. Well,
actually, it wasn't that bad. It was an interesting thing to do. And I was able to keep my family with me, and we went to California for 2 years. And so as a military physician, the hours were during the day were quite constrained, so I was not used to going home at 4 o'clock. So,
I'm sure you weren't.
so that was not too bad. The only other problem with it was that when you were the man on duty at night, you took care of everything, adults and anything that came along. So,
and then after you finished your commitment, you came back and you rejoined Dr. Lee.
Right, and then Dr. Kim joined us in the early 70s.
Okay, and then you were in practice again, and then you decided you were taking a special interest in your patients who had diabetes and hormonal disorders, and there was an opportunity for you to study that further. And what happened then?
Well, I had had the experience of leaving practice for 2 years and nothing bad happened. So when this opportunity came up in 1979, I took it to become a pediatric endocrinologist.
And where was that?
At Children's Hospital of Pittsburgh.
In Pittsburgh. So you had to move again.
We did. We did.
And maybe getting more to your specialty and the types of patients that you see. You know, as I mentioned in the opening, you know, I think a lot of people may not necessarily realize that, you know, children, in addition to having colds and falling down and getting this or that, they can have and develop diabetes. What type of person or child is vulnerable to that?
Well, we're trying to figure that out, actually. The NIH has a study that we participate in, screening families of new onset diabetes. But any child can develop diabetes. There's no set phenotype, set type of child.
Do children develop diabetes for different reasons than adults do?
Yes. The majority of children who have diabetes have insulin dependent. In other words, their immune system has destroyed the beta cells that secrete insulin in the pancreas. Those are the only cells in the body that secrete insulin, and they can be destroyed by an autoimmune process. Some children who become very obese can get type 2, which used to be called adult onset, but now we know that it's insulin resistance.
And so the immunologic aspect of children developing diabetes, is that something that is brought on by sometimes an infection, or can it be somewhat inherited? Or is still not known?
Well, yes, to both. The ability to develop diabetes can be inherited. We have families that have great numbers of children with diabetes in the family, but about 80% of our cases, there's no family history of children with diabetes. But the child will begin to develop diabetes, will show up with weight loss, drinking a lot of water, and perhaps wetting the bed and going to the bathroom all the time. The school may complain.
That's a good point to go over, because some parents may not necessarily be aware of what some of the signs of developing diabetes in their children may be. And we were talking at one point about sometimes a child may lose weight and a parent may feel pretty good about that if they needed to lose weight, but that may not necessarily be a good thing.
That is true. And if they're not dieting and trying to lose weight, and suddenly they begin to lose weight, diabetes or hyperthyroidism are conditions that need to be investigated. So you shouldn't, especially if a child loses a lot of weight, should not just say that's a good thing, that they're getting thin.
So drinking a lot of water, losing weight, needing to go to the bathroom more often sometimes can be signs.
Right.
And for a child who has diabetes, is it treated in the same way that adults, you said usually it's insulin dependent.
Correct. They need injections of insulin.
And how are children with that? You know, some adults often don't even like to have injections. Nobody really does, but how do you teach children to do that, and what is the process?
Well, when a child comes down with diabetes, that's just the first thing that's brought up. You have to take injections, and that hurdle just has to be overcome. Mm-hmm. During the first year, treat them with injections. They get one long-acting injection of insulin, and then they get, each time they eat, 3 times a day, they take an injection of short-acting. Mm-hmm. Modern needles are much finer than what you're used to. Mm-hmm. And so their injections are nothing like what they were when I started practice.
Some good things come with time.
The other good thing that's come with time is that since the 1990s have been the development of new types of insulin. Insulin analogs are not exactly the same as the insulin that's secreted. Mm-hmm. And so they've been tailored so that they will react quickly. So now you can be a little more free about the diet. You just have to calculate the amount of carbohydrate in the meal and get a shot for it. And then the long-acting takes care of your basal needs. We get insulin throughout the day to control our metabolism of glucose.
I've seen some pediatric patients who have an insulin pump. Is that unusual?
That is very usual. And we attempt to convert most of our patients to pump use.
I would think that would be ideal, probably.
It is.
In many ways.
It is now. The only problem with the pump is that it's like a car. It's only as good as the person managing it. Mm-hmm. So if the person is not willing to pay attention to using it, then it doesn't work at all.
What would you say is the earliest age a child may be a candidate for an insulin pump?
2.
Really?
1.
Wow.
I
didn't realize that.
The parents can operate it.
Okay, very good.
Yeah, so we do it very young.
Now, Dr. Transue, you also see pediatric patients who have thyroid abnormalities. How common is that, and which children are susceptible to that?
Well, it's fairly common. 1 in every 14,000 newborns is born with congenital hypothyroidism. They're hypothyroid when they're born. Mm-hmm. We're very fortunate. Since 1979, the state has been screening all newborns for hypothyroidism, because if we treat it within the first few weeks of life, these patients grow up and develop normally as they would. If we do not treat it during the first 6 months, they universally have abnormal brain development and are retarded.
That's an amazing advancement.
Yeah.
And thankfully, every newborn and every child is screened for that. Is that done throughout the country, or is that a state-by-state?
It used to be state-by-state, but now it's throughout the country. In fact, it's throughout the Western world.
That's good. I think that's a good thing. And how are children treated with thyroid abnormalities?
They're given oral thyroid medication once a day.
And is that very difficult to control, especially since the child is growing in stature and weight and going through metabolic changes?
It's very interesting. The newborn requires more insulin per unit of weight than a 5-year-old. So once the dose is established, and usually it's about 50 micrograms a day, the dose will stay the same as long as they get it every day until
the child grows into their dose.
Right. As they get older, they require less and less.
Mm-hmm. Interesting. Now, is a patient who has either diabetes or a thyroid abnormality more susceptible to endocrine disorders in general? That may they have more than one, or not necessarily so?
They may. Due to the autoimmune nature, There's a higher incidence of autoimmune thyroid disease in patients with diabetes. There are some conditions where you keep losing endocrine glands as they grow.
And another thing that you were sharing with me that you see a lot of in your patients is the issue of obesity, which really is becoming, childhood obesity we're more aware is more of a national concern. What are your thoughts on that?
Well, several things have happened, but since 1990, it was in the 90s that I saw my first type 2 diabetes, and now we're seeing that much more commonly. But probably 1 in every 3 or 4 kids is overweight. And one thing that's happened is that there's less activity and more sitting in front of a screen, so they don't get as much exercise. Parents are concerned about safety. So when I was a kid, we just went out the door. Nobody cared. So now they can't do that. And parents are concerned that for the child's safety, especially in certain areas, more so than in others. Kids like to play games, and they just exercise their thumbs with Game Boys and telephones and things.
I'm sure you must see a lot of that.
The other thing that happened is that high fructose corn syrup became available in the 70s, and it's cheap. And fructose is more sweet than any other type of sugar. And so sodas have become relatively cheap. If I wanted a soda when I was a kid, it took a half of my week's allowance, which was a dime, so it took a nickel. But sodas used to be in 6.5-ounce bottles. And then they went up to 10 ounces and 12 ounces. And now 20 ounces is the standard. One can of 12-ounce soda a day, if it's in addition to what you eat, will cause you to gain an extra 12 pounds a year.
Wow, that's amazing. And it's really the cumulative effect of your daily intake.
Correct.
That adds up over time. You could really see why this is a growing problem that families and children face. It's sort of like a perfect storm of negative things in terms of obesity. The fact that and when I grew up too, we just went outside and played until the street lights came on, until it became dark.
Right.
And we were active in playing baseball and football and whatever else, biking. There's less of that today, more structured activities in terms of spontaneous play. There are more of these devices that kids love, adults love. And it's interesting what you had to say about the introduction of the high fructose corn syrup. And can people get addicted to that high level of sweetness and really crave it just because their body or their system get used to that?
We do think that it is, that it does cause a desire. And there's even some articles now that if the mother has high sugar during pregnancy, the baby is sensitized to that. And if the baby's fed a lot of juice, we're seeing overweight 6-month-olds.
Wow.
But if you look at the scale of a child who's a bit overweight at 2, then gains 5 pounds a year for 10 years, he's 50 pounds overweight. If he gains 10 pounds extra a year, he's 100 pounds overweight. And we are seeing teenagers that are 100 to 150, 200 pounds overweight.
That's sad and that's difficult.
It is. It's very difficult for them. It causes them social problems, causes them
health issues.
Health issues.
Yes. Now, another thing I just want to touch upon, Dr. Transue, is you see patients who have growth abnormalities.
That is true. Both too much and too little.
And tell us a little bit about that.
Well, predominantly, we're seeing short children who are just short.
Mm-hmm.
But they come from a short family, and so it's predictable that they're going to be short.
Mm-hmm.
Certain people from certain areas are taller than they are from other areas, and so we'll see those if there's a question. The serious issue is the child who doesn't grow.
Mm-hmm.
And so we expect children between 5 and puberty to grow 2 inches a year, give or take a quarter inch.
And what can you do for that?
Well, if they're not growing, we need to find out why. It can be hypothyroidism, it can be growth hormone deficiency, it can be gastrointestinal disorders that interfere with nutrition, like celiac disease. If they're growing too much, then we have to look at other issues, like too much growth hormone.
So it's a matter of discovery of the underlying cause and addressing that issue.
But the main thing for discovering these problems is the physician, the private physician that sees these people, keep a growth curve. And we have charts. And if you plot their growth and they stay in their percentile, they have normal growth. They're a healthy kid.
Dr. Transue, as our time is winding down,
Okay.
How would a potential family contact you if they thought that they could benefit from your services?
Well, their family practitioner or their pediatrician can refer them.
Mm-hmm.
They can phone the St. John Hospital, and they have a physician referral service.
Mm-hmm. And
our office phone number was on your screen when we came on.
Okay, all right. I would imagine, but I'm just going to ask, with all the things going on with children and families, are you able to offer counseling and support services to help kids get through these different issues and families?
Well, there is a child psychologist with St. John's,
Mm-hmm.
Dr. McMillan,
Mm-hmm.
and we are attempting to have him in our clinic on a regular basis.
And I think you shared with me that you just, by the nature of your work, you do that on a regular basis anyway, because it's more needed time.
Yes, these conditions require much more time than the average pediatric visit.
And speaking of time, our time has run by.
Okay.
And thank you, Dr. Transue. Very much appreciate that.
Well, thank you for
and
asking.
thank you to our viewers as well. We always appreciate that you tune in to watch our show. Take good care of yourselves and those around you, and have a great day. We'll see you next time.